it's my pleasure to introduce today's speaker. Dr. Megan Cooney is a pediatrician and adolescent medicine specialist. She is section head of the Child Protection Center and holds an area of focused competence in child maltreatment pediatrics. Dr. Cooney has been qualified to provide expert opinion testimony in both family and criminal court proceedings. In court proceedings, she has served as a medical expert for both prosecution and defense. She is passionate about improving care for children who have experienced violence. I'll now turn things over to Dr. Cooney to lead us through today's session. Thank you so much for being here.
Thank you very much, Meg. Hello, can I just get a thumbs up if everyone can hear me? Perfect. My headset is not working, so the volume from my end is like very quiet, but as long as the volume on the other end is fine, that is perfect. So my name is Megan. I'm a pediatrician and I'm section head of Child Protection Center, as was mentioned. And we're going to be spending the next hour or so talking a little bit about sentinel injuries and what those are and why those are super relevant to anybody working in an emergency department and also in any type of primary care clinic as well. I'm happy to, I'm fine answering questions at the end or along the way, so really whatever works best. I'm not always good at presenting and keeping an eye on the chat at the same time, so if there is something that comes up, I'm happy to kind of take that either during the talk or afterwards. Either way works for me, if someone can alert me to it though. So our objectives today are to talk about what sentinel injuries are, either if this is a term that you haven't heard before, or if it's one that you're very familiar with, getting a bit of an update on it, and understanding the importance of sentinel injuries as indicators of physical abuse. We are going to be talking about an approach to the presentation of sentinel injury in the emergency department. And we're also going to review reporting requirements and strategies for discussing concerns for child physical abuse with both caregivers and with Child Protective Services. So with that, we will get started. So a sentinel injury, really to start at the point of the definition, because I think it's a term that many people are aware of, some people are not aware of, some people see it pop up on the screen when they're working in the emergency department and may have more or less knowledge about what it is. So my first goal is really just to talk about what it is we're talking about today. So a sentinel injury at the most basic level is a medically minor injury that precedes more severe abuse. And when we think about what a sentinel is and really where the word comes from, what a sentinel is, to the best of my understanding in the military, is someone who watches or keeps guard to really be on the lookout for danger that might be coming. So applied to injury, these are really medically minor injuries that should inform to alert us of a child who may be in danger of currently experiencing significant physical abuse, or potentially that is something that is coming for that child in the future if there's no intervention. So these are the types of injuries that we're talking about today. So some common examples of sentinel injuries and what we're talking about is mainly two types of injuries: bruises and oral injuries. Some people also include burns in this, but it's significantly less common. If we see in our first picture here, we have a young infant with a bruise on the side of the mouth. The middle picture represents a healed frenulum laceration, and the picture on the other side represents a small bruise on the forehead of a very young infant. So all of these would be examples of possible sentinel injuries. So what do all of these injuries have in common? First, they're medically minor. If you're seeing a kid with one of these in the emergency department, you might be wondering if it is even appropriate for them to be in an emergency department. These are so minor. So bruises are minor. Small oral lacerations, they're very minor. They're not anything that's ever going to need to be treated. So really, from a medical perspective, they're not something that us as physicians would be worried about in terms of the actual impact on the child. We all know that bruises are going to heal. We all know that small oral injuries are going to heal. So medically minor is the first thing that these all have in common. The second thing is that for the purpose of this discussion, we are mostly talking about these injuries in the context of pre-cruising children. So that means children that are not yet pulling to stand and furniture walking. So really young kids, the age group where if you put them somewhere, they'll stay exactly where you put them. And the reason why we focus on this age group and talking about sentinel injury is because this is the most high yield group. This is the group where we know that having bruises as the result of accidents is really, really, really uncommon unless there's a very clear history of an accident that makes sense that the child has sustained, typically when they're actually in the care of somebody. So when kids in this age group have accidental injuries, it is most common that there is a caregiver that knows exactly what happened. So we're going to talk a little bit about how that is different than perhaps a caregiver who might speculate as to how it happened. So for example, there's a difference between giving a very clear history of I was holding the baby and I tripped over something and the baby fell from my arms and hit the floor. Like that's a very plausible thing that could happen to a child, as opposed to hearing from a caregiver that, you know, oh, one of the older kids must have thrown a toy at the child. One of the older kids perhaps was rough with the child. Things that are more speculative, things that people haven't seen, are in the category of injuries that we would be concerned about, mechanisms that we would be concerned about. So we know that true accidents in this age group is pretty rare. And when they do happen, there's a pretty straightforward explanation for them. And again, these are injuries that are either completely unexplained, meaning no one has any idea how they got there, or they're poorly explained, meaning people are speculating about how they happened, or they're providing you with mechanisms of trauma that really don't make the most sense. So, as I was alluding to, in order to really talk about sentinel injuries and how this is something that can in fact be used in your clinical practice to help pick out kids that are at risk of significant injury due to physical abuse, we have to know how common bruises actually are in kids. So this is from a really neat study that was done quite a while ago. It was done in 1999. I have not seen anything like this be repeated since, but it was a really smart study where they actually prospectively looked at almost 1,000 kids coming into a family doctor's office just for regular, routine, well child care. And all of those children had head to toe examinations for bruises. What they found was that only 2.2% of pre-mobile children had bruises at all. And when we broke down the age groups, that was only a 0.6% of children who were younger than 6 months. So all comers into a family doctor's office for well childcare, only 0.6% of kids 12 months or less actually have bruises. So we know that bruises are a really uncommon thing to see in kids who are very young and not moving. So by definition, whenever we are seeing these things, it is reasonable to ask ourselves the question, at least, is it possible that this bruise might have happened because of something like physical abuse? Again, doesn't mean 100% of the time that's what it is. But when something is so rare to begin with, and we know that physical abuse is actually quite common, raising the question is certainly something that's indicated, especially in these really young child. On the other hand of things, and why I really like to have the focus be on these really young pre-mobile kids, is that we know as soon as kids start cruising, they bruise everywhere. And anyone who works with kids in any capacity can very much attest to this. So this study showed that 17.8% of cruising children had bruises, and over half of kids who are walking had bruises. What we learned about those kids that were in the walking age from the study is that though they did have bruises, they tended to have about 3 to 4 bruises a kid, with a range from 1 to 11 bruises. And the location of almost all of those bruises was on the anterior lower legs, anywhere on the upper parts of the legs, and on the forehead. We learned that the torso and the face were pretty uncommon locations for kids to bruise. And we also learned that in that prospective study of almost 1,000 kids, no one actually had bruises on the hands or the buttocks. So these are locations that are pretty unusual for kids to have bruising. So how common are oral injuries? So a more recent prospective study that was done out of the US looked at all comers to a children's emergency department and found that 2.8% of the children evaluated had presented with an oral injury. Most of those were immobile children, and most of those were coming in with traumatic chief complaints that seemed like very reasonable explanations. It was a very small proportion of kids. I think there was only 3 kids who were non-mobile and coming in with oral injuries that did not have clear explanations. So again, this is not a common thing that we see. Oral injuries as a total of presentations to emergency departments are uncommon, and especially unexplained oral injuries in very young babies are extremely uncommon. So why is this even important? It's important because we know that these medically minor injuries are actually very strong predictors of possible child physical abuse. They can alert us either to kids who actually currently have more significant underlying injury if we investigate it, or potentially kids who are at risk of more significant things happening to them in the future. We know that there is a higher mortality rate in abused kids presenting with a recurrent evaluation for physical abuse compared with the first presentation. So there's been a few retrospective studies that have demonstrated that very nicely, that the mortality rate due to presentations for possible physical abuse, it increases with each subsequent presentation. So if we want to have an opportunity to have maximal impact, having an intervention happen at that first presentation is going to prevent those higher numbers and that increased risk later on. We know that these medically minor injuries are often overlooked, and there's a variety of reasons for that we're going to discuss during the presentation. In the original paper that was published that coined this term Sentinel Injuries back in 2013, the really shocking statistic from that paper was that over 25% of seriously abused children, so this is children who ended up either dead as a result of their abuse or ended up with catastrophic brain injuries. 25% of those kids, over 25% of them, had a previous sentinel injury. And really what was more shocking was that more than half of those previous sentinel injuries had actually been known and seen by healthcare providers in approximately the week prior, somewhere in the week prior in most cases. So this is actually a pretty significant number of kids that we have the potential to have a different outcome in if we become more alert to the potential risks and dangers of these medically minor injuries. Because in many cases, and over 25% of cases, this is actually something that as a health system, we could have had the opportunity to predict. So this is a study that looked at data from their children's emergency department. This is out of the US. And what they found was that over a 3-year period, they had 3 cases of missed physical abuse prior to fatal presentations. And the age range of those kids, you can see it's all in that very young age group of kids, 2.5, 3.5, and 6 months. And some of the things that we're seeing as close as proximal to the fatal event is 24 hours before. So this is a common thing that is seen in emergency departments and something that is very easy to overlook and gets overlooked everywhere. There has been a lot of literature that's looked at predicting recurrent presentations of physical abuse. And what it's found that factors that are associated with recurrent presentations. So to be clear, when I'm saying recurrent presentations, I mean there was an initial presentation that either raised or should have raised, in retrospect, concern for physical abuse, where the child was discharged and suddenly subsequently returned to the emergency department with a second or third presentation concerning for physical abuse. So those risk factors are 1, folks who are living in a rural area, superficial injuries. So superficial injuries is significant because what that tells me is that when kids are coming in, and it makes total sense, with more than superficial injuries, these are the cases that really are alerting all of us to the potential of physical abuse. But the group where we are missing are the kids coming in with the more superficial injuries. So things like lacerations, things like bruises. And kids with open wounds were also more likely to either have not had those questions raised, or to have had those questions raised without subsequent intervention that resulted in the second presentation not happening. Factors that are associated with a decreased risk of recurrent presentation, and again, this makes total sense, is a child having multiple injuries at the time of the first presentation. And again, what that really, I think, is a marker of is the fact that the more injuries a child has, the more serious the injuries, the more likely all of us are to be concerned about the possibility for physical abuse. So we're already doing a decent job at the more serious stuff, the kids coming in with multiple injuries. The group where there is room to have greater recognition is really those kids that are coming in with the things that are more medically minor. So there are a lot of reasons why sentinel injuries get missed. This particular study was done over 20 years ago, and I actually think it would be really interesting to repeat 20 years later, because I think there's just a lot in the climate of medicine and our society that has changed during that time. But the main reasons identified why these injuries get missed are, one, really failure to recognize that medically minor injuries can possibly represent child physical abuse, which again, it makes sense, because when we see a bruise in a 2-year-old, like, on the balance of things, no one's thinking of child physical abuse, and on the balance of things, no one should, assuming it's like a small bruise on a forehead or a leg or something like that. However, what we need to do is make sure not to translate how we look at a bruise in an older kid into how we look at the same bruise in a child that isn't yet moving for themselves. So that's one of the reasons. Another one of the reasons is failure to recognize that there actually is a correlation between minor injury and subsequent more serious injury. So some folks interviewed would acknowledge that, like, yes, I was concerned about why the child had a bruise, but at the end of the day, it was just a bruise. And really not recognizing that just a bruise today could be something actually fatal tomorrow, was another one of the reasons. Another reason is concerning that reporting will harm the therapeutic relationship. This is so true, and I think that anyone who has any type of primary care practice can probably very much relate to the worries that raising concern for child physical abuse would cause, if done in the context of a therapeutic relationship that you've had with a family for quite some time. And I think, even in the context of an emergency department, recognizing first there's people that get seen by you all on more than one occasion and develop these relationships with, even though it is an emergency department, but also recognizing just the therapeutic relationship that exists and wanting people to feel comfortable going to an emergency department in general. The worry that if I raise this concern, if I make this report, am I going to make this family more worried about actually coming back in the future, is a very real thing and is a very valid thing. Lack of time in a busy clinical setting is also very real. We all know that we are all very busy and we run around doing a million things at the same time. And the truth is, taking time to disclose your concern to a family and taking time to disclose your concern to Child and Family Services and some of the follow-up that might happen after that is a very real thing, that there are many days that there just might not feel like there is time for. And finally, and again, this is very real, and this is something that is, I will say, as someone who works professionally in the area, on my mind every single day, is the fear of the impact, the fear that the report could have a negative impact in the family. And what people state is that, especially when they feel that there is no proof. And I think what is important to remember here is a few things. We're going to talk a little bit actually about what the CFS legislation looks like, and how, in fact, if we are waiting to the point to get to proof that somebody was hurt, first of all, I think that's actually probably technically impossible because, in the purest sense, we as physicians can never be completely sure that somebody has been hurt or not hurt, though there's times where we can be pretty close to sure. And also waiting to proof, even if it was possible, is actually not what the legislation wants us to do. Recognizing that this fear that you could have a negative impact on the family, that is very real, and that is very legitimately something that happens. That being said, it needs to be balanced against what could happen to the child if a report is not actually made. And I think it is easier for many of us to relate to the experience of the parents when we're seeing pediatrics, because I think many of us very naturally put ourselves in the position of that parent and think, like, what is this going to do to this family? How is this person going to feel? How is this going to impact the family if I make a report? And if there's a safety plan in place, or if there's a risk that the child is apprehended, those are very real. But I think what we also have to be mindful of is putting ourselves in the position of a very young baby that actually has no ability to protect itself, if there is something concerning, and if there is violence that is occurring to the child at home. So it's really trying to balance those things, which is quite hard, and is not something that I say lightly by any means. If I'm likely to lose sleep over one thing, it is actually this often. So this is very real too. I think that when we look at the literature, and when we kind of talk to people in cases where this has happened, one of the common comments that we get is people are hesitant to report because the families seem very nice. And this is actually one of the most common, if not the most common, reasons for not reporting sentinel injuries, is that as physicians, we can have a tendency to really over-rely on our abilities to judge the caregiver, the character of the caregivers. And the truth is that it's just flawed from many perspectives looking at it like that. Because first off, when a child presents with concerns for possible physical abuse, we actually don't know if they're presenting with an offending caregiver or a non-offending caregiver. We don't know if assuming that if the child was injured, we actually don't know who injured the child. So many times the caregiver that they're presenting with, they actually are very safe and protective. That's why they brought the kid to an emergency department. So sometimes that can be the reason why, we have this feeling that the family seem very nice. I couldn't picture them as people that would hurt their child. What also plays into that is societal misconceptions about why child physical abuse actually occurs. There is certainly a narrative that exists that people that abuse children are very mean and bad people who often dislike their children and who are doing it intentionally or doing it on purpose. What we know from the literature, and there's been really good literature that actually looks at folks who have confessed to significantly harming their child fatally and with catastrophic injuries, people who have confessed to that. And they do a lot of this work actually out of France, because they have a bit of a different justice system over there, where you don't actually get a deal for confessing. So it's felt that some of the research that comes out of France in talking about how confessions work is potentially more valid than research that would come out of a place where you potentially can get less of a prison sentence if you're making a confession. So what we know from that literature is that people who fatally hurt their kids don't actually intend to do that. It is something that ends up happening in the heat of the moment because of very poor distress tolerance and poor coping, happening in the context of often a very young infant that is very challenging to care for. And young infants are challenging to care for. So there is massive misconceptions about, quote unquote, the type of person that would abuse a child. And I think that the reality is most people are the types of people that could abuse a child under the right circumstances, under the right stressors. And we cannot use our judge of character in order to determine who is at risk and who is not at risk. It's very problematic, and it actually results in a lot of times kids going home into situations where there is an escalating pattern of abuse that is happening. So that really brings us, if that is true, how can we actually identify these children who are at risk while mitigating bias, recognizing that bias is real and that bias exists in all of our clinical practices? We have to make sure that we're considering the possibility of physical abuse when there are red flags present. When there are objective reasons to be concerned for physical abuse, that needs to be when we are considering the possibility of physical abuse. Risk factors are very important from a population health level. So risk factors for child physical abuse are things like, having a baby born prematurely, being in a single parent household, living in poverty, having a parent with mental illness or with substance use disorder. So these are risk factors. These are very important at a population level, and they're very important for targeting public health interventions to try to decrease societal rates of child abuse. That said, they are not useful when it comes to decision making for individual patients that we're seeing. And I'm going to provide some examples that really highlight that. So this example, in which child are you concerned for the possibility of physical abuse? Child number 1 is a 3-year-old child with a forehead bruise. There is risk factors present. So there is a parent that uses substances and they're living in poverty. The second child is a 3-year-old with a forehead bruise with no risk factors. Which child are you concerned for physical abuse in? The answer is neither of them, because both cases are a 3-year-old with a forehead bruise. And we know from the literature and from really living in everyday lives that 3-year-olds get forehead bruises all the time. So we're actually not concerned that that bruise is from physical abuse in either of these children. If we change a 3-month-old or 3-year-old into a 3-month-old, so we have a 3-month-old with a forehead bruise with these risk factors. And then we have a 3-month-old with a forehead bruise with absolutely no risk factors. Which child are we concerned about? The correct answer is we're concerned about both of them. And the reason why we're concerned about both of them has nothing to do with the risk factors and everything to do with the fact that we have a 3-month-old child with an unexplained forehead bruise. So that brings us to, so this is pulled directly actually from the TREKK bottom line recommendations for physical abuse. That brings us to, what are these red flags, right? If we're supposed to be relying on red flags, what are they? So this resource actually is super helpful in talking about many of them. So first, having a serious injury without history of significant trauma, I think that speaks for itself, that would be a concerning red flag to have on history. Second, an insufficiently explained delay in seeking care in a child with a clear injury. I think that, for this one, common sense sometimes needs to be used. I think that sometimes we get called and asked opinions in kids that say, let's say that there's a toddler who was not using their right arm for a couple of days before the family brought the child in, and on bringing the child in, we learned that there was like a buccal fracture. From my perspective, that is something that I actually wouldn't necessarily worry about, because I think that on the balance of things, a radial buccal fracture, a child not moving their arm for a couple of days, like unless they're super, super cranky for those couple of days, the truth is many parents would probably just think, oh, maybe they've sprained something, maybe there's some sort of soft tissue injury. Many parents wouldn't jump to broken arm in a situation like that. So I think a delay like that is actually something that is pretty reasonable. That said, when we hear delays where children were like having seizures at home, and like in a kid that like doesn't have known seizures, and there's still a delay in calling for EMS help by hours potentially, that's very concerning, because I think that we all know from experience that when something like a seizure happens in a child where there is not experience with seizure in the home, that would be a reason that most people would call EMS and most people would present for help. So we have to kind of consider delays in the context of what we see from our experience that other people would do in similar experiences. Having a history that is inconsistent between caregivers and or the child's developmental abilities. So essentially what this gets at is if you are having two people who witness the same thing who are saying very different things, and recognizing that that is different than when two people say different things and one person was there and one person wasn't, right? That's not an inconsistent story. That's just a game of telephone that hasn't gone wrong. So having stories that are very inconsistent with people who have seen the same thing, or having stories that are very inconsistent with one person who was there and having that story change over time. So I can provide a quick example. And it might be that if I'm seeing seeing a child who has a bruise on their cheek, and it's a baby, and I have a parent who says, oh, well, like it must have happened because the older sibling maybe threw a toy at them and the older sibling is like 2 years old. And if I would say, like that's actually not something that we would expect to cause a bruise, and then, oh, well, actually, they threw the toy and then I dropped the child. So like when the story is changing in the context of a conversation, when someone is getting feedback that maybe what they've said isn't plausible, that would be a concern. And then the children's developmental abilities. So an easy example of this is being told that a child crawled to the stairs and fell down them, and then you're examining the child and they're like 3 months old and clearly can't crawl. So always taking that developmental history and seeing if what we're being told actually aligns with the developmental abilities of the child. Red flags or exposure to family violence in the home. Serious injury being attributed to a young child or a pet. So again, I just used an explanation of my young child threw a toy and that must have caused the bruise. It must be maybe my dog jumped on them and caused a broken arm. And that said, there's some pretty big dogs out there, so I'm not saying it can never happen. But these are common things we see in kids who later go on to have abuse more definitively proven through things like the justice system. And finally, concern for abuse is identified by using a clinical decision tool, and I'm going to show you one of those on the next slide. So red flags for physical abuse with bruises. So again, accidental injuries, they usually occur over the bony prominences and the anterior surfaces of the body. So these are areas where it is not a red flag, but where we actually expect to see bruises. Any bruise in a child that is 4 months and under, even if it is very minor, this is the definition of a sentinel injury, and this is concerning for physical abuse unless there's a very, very clear explanation. And then finally, any bruise in a child who is 4 years old and under in a specific pattern, and this is where our clinical decision tool can come in handy. So this is a very helpful clinical decision tool that has been validated. And I think that it's also in the bottom line recommendation as well. I believe there's actually an image of it in that. And this rule is called 10-4 faces P. And it is, the faces P is, I feel like I'm not good with like memorizing rules and acronyms. So the faces P I sometimes have trouble remembering, but the 10-4 is the easier part to remember, and to be honest, probably the most high yield part of this. So what the 10 stands for is torso, ears, and neck. And I should have mentioned that this tool is validated for children who I believe it's either under 4 years or 4 years and under. It's somewhere close to 4 years where this tool is validated. So any bruise in a child within that age range to the torsos, the ears, and the neck is concerning for physical abuse potentially. Doesn't mean it's physical abuse every time, but it is enough of a concern to raise alarm bells, because these are locations where we know accidental bruises are very unusual. And the caveat that I will add to this is that when I say the torso, I'm speaking of the torso and areas of the torso that do not overlie bony prominences. So, for example, bruising over the anterior superior iliac spine is not something that concerns me. Bruising over the spinous processes in the midline of the back is not something that concerns me, because even though these are part of the torso, these are areas on the torso that directly overlie bony prominences and therefore will bruise from quite insignificant forces, as are often seen in childhood accidents. So torso, ears, and neck, with that caveat that we don't worry as much if it's overlying a bony prominence. And then the face is P. What that stands for is injury of the frenulum, the bruising to the angle of the jaw, bruising to the cheeks, specifically the fleshy part of the cheeks. Again, as a general rule, bruising on top of the cheekbone, there's a bony prominence right there. We do not worry about it as much. It's easier to bruise that area of the body than a more protected area with no bone underneath it. Bruising to the eyelids, and subconjunctival hemorrhages that are not explained by things like coughing, vomiting, and other reasons why we see subconjunctival hemorrhages. The P stands for patterned bruising. So again, any patterned bruising, specifically in kids this age, I would argue probably in any kid, but it's not validated, but patterned bruising in this age group is concerning for physical abuse. So what I mean by patterned is bruising that takes the shape of the object that strikes the child. So that can be linear bruises that we see in the context of like slap marks is the classic, bruising that has the appearance of something curvilinear, meaning it wraps around the body, which we can see in things like cords and belts. So you don't have to know what the pattern is. I don't know what the pattern is most of the time, but recognizing something as patterned. And then the really neat part of my job can sometimes be that at a case like this not too long ago, where I called something patterned bruising, but I had no idea like what pattern this is, but like it was clearly isolated, discrete, and patterned. And then I actually had the police bring me like a picture of a fly swatter, I think it was. And they're like, could this cause it? And then all of a sudden, as soon as you're looking at the fly swatter, you can see like, oh gosh, there's the handle, there's this part. So pattern, you don't have to know what caused it. You just have to recognize that it is not like small, round, oval-shaped, non-specific bruises. And then the most important part, I think, of this clinical decision tool is the 4. So the 4 means 2 things. It, in general, means that bruising in these areas or pattern bruising is concerning in a child who is under 4 years. And then more specifically, it's talking about literally any bruise to any surface of the body in a child 4 months and younger. So that's that group that is not moving for themselves yet. Again, definitely doesn't mean it's abuse every time, but it's unusual enough that it makes sense to raise the question. So more red flags for physical abuse. Looking at fractures. Any fracture in a non-ambulatory child, I think that just makes sense from the same perspective of why bruising in a non-ambulatory child would make sense. Unless there's a very clear history of how something could happen and it was witnessed, any fracture in a kid that does not move yet should raise concerns for physical abuse. We know specifically from work that happens out of a group in the UK that specifically actually humeral fractures in kids under 18 months are concerning for physical abuse. And that's just because when we look at data from a lot of different fractures, we see that they're actually pretty uncommon before 18 months. The ones that tend to be more concerning for the possibility of physical abuse are those like humeral shaft fractures. So if there's a type of humerus fracture that is less concerning, even in somewhat of the younger age group, it would be the fractures that the word's escaping me, you'll all know what it is, supracondylar around the elbow. Those ones tend to be a bit less concerning, but really any humeral fracture in a kid under 18 months, but especially those mid-shaft ones. Rib fractures, in a child who's under 3 years are very concerning. The ribs of very young children are pliable. Unlike adults, they actually don't break easy. We rarely see fractures as a result of things like CPR. And rib fractures actually have the highest predictive probability for child abuse compared to any other fractures. So rib fractures in young kids, super concerning. Classic metaphyseal fractures. These are fractures that we will typically only pick up on skeletal survey because they don't often have symptoms associated with them, though they can. And essentially what makes these fractures concerning is the fact that they're pretty uncommon, they're fairly unusual, and the mechanism that causes them tends to be indirect forces of inertial trauma, which we don't need to talk a lot about. But essentially, this is the mechanism that we see in things like when kids are shaken and thrown and slammed. It's the same forces that cause bad head injuries will cause these fractures. So that's why we tend to see these fractures in cases that are concerning for physical abuse. Fractures at different stages of healing. So again, I think that largely speaks for itself in that if you have multiple fractures and some are healed and some are not, that would be concerning. And finally, fractures of areas that are just generally pretty unusual and hard to fracture are concerning. Going to skip over head injury just because it's there for you, and we're mostly talking about minor injuries today. So what are we doing in our evaluation? We need to take a medical history that pertains to the injury at hand. Specifically within that, we want to know, is there a history of trauma or not? If yes, having a detailed mechanism is super helpful. Again, I've heard many ways that children can fall off of couches and beds and downstairs, and having that detailed mechanism can sometimes be the difference between being concerned and not being concerned. If there is no history of trauma, it's helpful to know when the last time the child was seen without the injury. We want to know if there are symptoms that are concerning for the possibility of head trauma, even in these kids who are coming in with superficial minor injuries. So is the child presenting with a bruise, but are they also irritable, lethargic, vomiting, poor feeding? Have they had apneas? So we want to know about the presence of any of those symptoms. We would also like to know if there is history to suggest a previous sentinel injury. So by that, I mean, has there been previous bruising, oral bleeding, subconjunctival hemorrhages in that little age category that we're talking about? And to be honest, it fascinates me how many times when you're asking these questions, when we know that bruising to begin with is just so unusual in this age group, and you'll say, has this 4-month-old ever had a previous bruise? And then they'll say, oh yeah, now that you mention it, and they'll show you on the phone pictures of all of the other bruises that the child has had. And again, doesn't mean it's necessarily physical abuse. There's medical things that we need to think about too, but it definitely deserves raising the question. So asking about a history of previous sentinel injury can be very helpful. Questions about things that can mimic trauma, like bleeding disorders, is important. And finally, the developmental ability of the child. So on our exam, we need to do a complete physical that includes head to toe skin exam with undressing the infant. I recognize that there are circumstances where it might not be possible to undress an infant completely. However, just my little shout out, if we can document when they aren't undressed, or if they have been undressed, it's super helpful for me, because when I'm actually reading your documentation on my end about, and it says like no other bruises, but I don't actually know if they were completely undressed, it's just helpful for me to know if they were or weren't. And any time that you're able to, undressing them is super helpful and important. Finally, mandatory reporting. So we're going to spend a bit of time talking about this. So healthcare providers in Canada are mandated by law to report concerns for child abuse to the mandated Child Protective Services Agency. So for us here in Manitoba, this is Child and Family Services. So what does the Act actually say about reporting? So the Act talks about a child in need of protection. And within the Act, what a child in need of protection, it is a child in need of protection where the life, health, and emotional well-being of the child is endangered by an act of omission of a person. So the Act talks specifically about this child in need of protection. Physical abuse is defined, or abuse rather, is defined for the purposes of the CFS Act. and when to report is important. So what the Act says is that if we have information that leads us to believe that a child is or might be in the need of protection, then we have to report that information. So the agency that we report to is CFS, and theoretically, if it is not a caregiver who is involved, you can report it to the caregiver. However, I don't know if I would have ever reported to a caregiver and not CFS. I think I've done that once. I don't know if that makes sense most of the time. So reporting to CFS is what we need to do if we are seeing a child who we think might be in need of protection. So the key there is we do not have to know for sure. We just have to be questioning it. It's important that we are not reporting, this is again directly from the Act, just based off of socioeconomic conditions like poverty, lack of housing, infrastructure, state of the parent or their care provider. So the concern for protection has to be independent of those things. So how do we actually discuss these concerns with the caregiver? Because we know actually that this is one of the big barriers to reporting. So it goes without being said, taking a non-judgmental and empathetic tone is really important. And from my perspective, I think that that is a really easy thing to do most days, because I think that as a parent, I would want the person who is having this conversation with me to be very non-judgmental and empathetic. And I think it's important to remember that in these circumstances, we do actually have a lot of common ground with these caregivers. Number one, we might be talking to a non-offending parent. We don't know who we're talking to. And that person has probably presented to emergency in many cases with not a consideration that trauma actually is the reason why the child has been injured. Because though this is not always true, many people are with people who they trust, and they would not think that other caregivers would be capable of that. So important to be non-judgmental and empathetic, because we might be with a non-offending caregiver. And I would argue, even if we are with the offending caregiver, that person has cared enough to present for medical care. So our common ground is that for the most part, everyone we're having this conversation with does actually care about the child. And I think that that's something that's important to return to during the conversation. It's important to discuss your objective concern. I talk in detail about how we think as doctors and about how diagnostic process works. So when I see a bruise, there's different things that pop into my head about could be causing that. Number one, could it have been caused by trauma? If it was caused by trauma, does it make sense that it was an accident? And then also, are there underlying conditions that could be leading to this bruising? And these are all things that we think about when we're trying to help figure out what's happened to a child. So I really kind of explain how we think as doctors and explain the medical reasoning behind my concern. And in a bruise in a young child, that is that, as a physician, when I see a bruise in a young child and there's not a clear, straightforward explanation, this is something that I'm concerned about, because I do actually know that the most common reason for that is that somebody has hurt the child. So that's why it's something that I'm concerned about in these circumstances. Discuss that you will be reporting to CFS in the context of your concern for the child rather than legal necessity. A lot of people, when they are doing the active mandatory reporting, will actually state I have to report this because I'm a mandatory reporter. And while that is true, my experience has been that that does not go over well with most people. And I think that people can relate more to somebody who is reporting because they are concerned about the child versus somebody that, I'm not concerned, but it's my duty. I have to. The law says I have to. I don't want to get in trouble. So I think that it is helpful to always explain the need to report in the context of your concern. Because I think that if we lived in a world without mandatory reporting, the reality is I would still report every case I've ever reported. I don't do it because the law says I have to. I do it because I'm genuinely concerned about what could happen to the child if I don't. So this is just a very brief example of kind of how I would typically have a conversation about this. I'm concerned we don't have a good explanation for why your child has this bruise. One of the possible causes is that someone has hurt your child. I always ask, is this something you've been worried about? Because gosh, when they say yes, it makes the next part so much easier. And to be honest, it's not an infrequent number of times that is something that people are also worried about. I will then go on to say something like, I understand you're not concerned, or I hear that you're concerned and I agree with you. However, because I'm concerned that someone has hurt your child, I will be notifying CFS and our medical team that specializes in, I mean, that's technically me. So I explain that because I'm concerned, I will be doing these things. And that is how I will typically make these types of disclosures. Also important to talk about is how we actually talk about these concerns with CFS. Because there is an art to talking to CFS, it is important to recognize that when we are talking to them, we are often talking to people with zero medical background whatsoever. So when we start like using medical terms, they have no idea what we're saying half of the time. So I actually do use this mnemonic, even though I generally can't remember mnemonics when I'm talking with CFS. And if I have a minute, I always take a minute to think about what I'm going to say before I pick up the phone. ICE stands for information, concern, and context, and the expected impact that it has on the child. And again, it is okay to not have all the answers when you call CFS. So I will not read this whole thing, but essentially what this goes through is basically explaining, you explain who you are, where you are working, who you are seeing, the information that you happen to have on file. If you know where the child is at this moment, such as they're in my emergency department, that is helpful for them to know. I then explain what my concern is in the context of it. So in a little kid with a fracture or a bruise, I'm concerned because they have a bruise without an explanation. And we know that this often represents a sentinel injury, which although it is minor and does not have a large impact on the child, could be a predictor of a child who is at risk and could represent child physical abuse in the home. So explaining the concern in the context and then the expected impact. So what that means is essentially, for the most part in an emergency department, is whether you're discharging them home or not. So this kid is ready to go home and I'll be discharging them within the next hour. And it's important for CFS to know kind of what your timeline is so that they can have time to figure out what they're going to do. So medical tests for possible sentinel injuries. Again, this is taken directly from the bottom line recommendations and is for, and I should be clear that these recommendations are for child physical abuse and are not specific for kids who are coming in with medically minor injuries. But I think one of the biggest takeaways from this that I'm going to talk about is the concept of screening versus diagnostic tests. So the tests that we do when we're assessing for possible injuries largely are tests that are screening tests and are meant to look for occult injuries. So injuries that we can only find if we actually go and look for them. So for example, if a child, a 3-month-old who's coming in with an altered level of consciousness, if you're doing neuroimaging in that case, that is a diagnostic test that has been done. You're not doing that, to look for signs that the kid has no symptoms of, like the kid is coming in altered, they're getting a head CT. If you're seeing subdural hemorrhages and edema, like you did that test for the purpose of diagnosing why the child was altered. When we're seeing a 3-month-old with a single bruise, every time we're going to recommend neuroimaging. Again, unless there's the clearest explanation that for some reason makes us not worried, we're going to recommend it. And we're going to recommend it even though the neuro exam is normal and even though they're not having symptoms. And the reason for that is when there are no symptoms, I am not doing it as a diagnostic test. I'm doing it as a screening test. And I'm doing it as a screening test because I know there's about a 15 to 20% pickup of kids who have a medically minor visible injury who will actually have head injury when we do their neuroimaging. Occult head injury. So it's often subdural hemorrhages, diffuse subdural hemorrhages is often what we see. So even though the neuro exam is normal, even though they're not having any of those neuro symptoms, that is why we're recommending it, because there's a very decent, reasonable pickup of kids that have occult head injury. Same thing for fractures. The 3-month-old is coming in with right upper arm swelling. You're doing x-rays for the purpose of diagnosing why the arm is swollen. It's a diagnostic test. If a 3-month-old is coming in, again, with a non-specific bruise, I'm going to recommend doing a skeletal survey. And I'm recommending that because I am actually looking for occult fractures, things that I can't tell by doing my exam. So things like rib fractures, CMLs, healing fractures. So I need to do this screening test because I have no way of determining from examining them if these fractures are there or not. So essentially, for sentinel injury evaluation, thorough history and physical, including that full skin exam. If there are concerns on history or physical, we need to do neuroimaging, skeletal surveys, and lab investigations, specifically AST and ALT, to screen for occult abdominal trauma. And anyone in the province, anyone in the Kivalliq region of Nunavut, and anyone in the area of Ontario that we serve, please call us. It is me or one other person on call typically. And I am not lying when I'm saying these are actually calls that we want to receive. I recognize that most of the people on this talk right now are people that are not actually working at centers that do skeletal surveys. When we are seeing little kids under that 6-month age with sentinel injuries, these are kids that we arrange to see in our clinic for skeletal surveys. So please call us. We genuinely do want to know about all of these kids. And this kind of becomes a question. Can physical abuse actually be ruled out? To be honest, unless there is an alternative explanation that comes up, it's really hard, if not impossible, to rule out. And if you think about seeing a kid with a single bruise on the cheek or the chest or wherever it is, assuming it's like a 2-3-month-old kid, say that we do all the tests and it doesn't show any injuries. The reality is there's still a bruise that is completely unexplained in a kid that shouldn't be getting bruises. So regardless of the results of the test, it actually doesn't negate my initial concern. I have not ruled out abuse by doing those tests. I have ruled out the fact, I now know there's no occult fractures or head injury. I still don't have a good explanation for a bruise that shouldn't be there. So no medical test can really rule this possibility out. There's also no medical test that can conclusively diagnose it. And that is why Child Protective Services is required in many cases, in most cases, as parts of these assessments, because as physicians, we actually don't know the dynamics of the family. We have no ability to go into the house. We don't know if there's a history. There's a lot that we don't know that we need other partners to look into. So again, we don't know anything, but life exists on a spectrum of I'm not that concerned to I'm extremely concerned. So finally, my take-home points really are medical minor injuries. By definition, they're minor, but they do often precede more severe abuse, and it's important not to overlook them. Evaluation of an injury that is concerning for physical abuse, it should be based off of those red flags. And again, the TREKK resource is great. It should be based off of objective findings, not our assessment of the character of the caregivers. A validated tool, the 10-4 Phases P, does exist and should be used. Super helpful for kind of reminding us what bruises are bruises that we should be more or less worried about. And screening for occult injury is important and should happen even if the exam is normal and symptoms are absent. Finally, it's a responsibility of the health system to report objective concerns, but it is not our responsibility to determine if physical abuse has occurred. There's like other systems that actually specialize in doing that. So we do the medical assessment that makes sense for the health of the child. We report our concerns, but it is not our job to actually prove that something has happened or not happened. So with that, I can take questions if there are any.